Today, I sat down with the incredible Jennifer Gularson. She is a physician's assistant residing in the Washington, D.C., Maryland, Virginia area, DMV. We had the most delightful conversation. It was so good. We unpacked so much about hormone therapy, peptides, as in GLP-1 agonists. We talked about loss of libido, loss of sense of self and purpose, weight gain. We talked about everything that's wrong with our healthcare system and everything that could be right with our healthcare system. It was a beautiful intersection between science and spirituality. Well, mostly science. And I geeked out on the science. What Jennifer was able to unpack for us in terms of what's happening in the female body and remedies and modalities and even hormone therapy to help it, she explained it in such a way that was truly understandable, the way listeners will truly grasp it. And I can't wait for you to hear this episode. Science aside, the spirituality part was mostly about leaning into who we are as women and claiming our power, claiming our feminine side too, which means, self-care and nurturing, tapping into our wisdom. I say this often. Women become wise as they step through all those years of experience, all those years of doing, and come out on the other side more empathetic, more in touch with their bodies, and more in touch with their abilities. So we definitely tapped on that spiritual part of it, if you will. This was one of those conversations that could have gone on forever. It really did. And I think that it would be wise to bring Jennifer back. But certainly for this episode, listeners, grab a pen and paper or get your voice memos out while you are listening to this one. There's a lot in here, a lot to digest. But before we begin, here's something you need to know about Jennifer Gularson. Jennifer is a certified physician assistant and certified functional medicine practitioner. She specializes in integrative functional medicine and aesthetics, using a holistic, patient-specific, systems-oriented approach, looking at many factors such as lifestyle, genetics, and the environment. Her goal is to address underlying imbalances and root causes that can help promote overall well-being and put the woman back in control, rather than just giving her a Band-Aid solution to manage symptoms alone. And Jennifer focuses on women's health. She's been treating women in the ages of 35 to 60 for a long time and noticed there was so much stigma attached to menopause, also known as the misery. It wasn't a glamorous subject, and women felt misunderstood, and often treated with antidepressants, and frustrated when they were told, it's just the way it is. Get a good night's sleep, honey. It will eventually go away. Well, the true disruptor that Jennifer is, she works with her patients so that they feel safe, without judgment, without the shame, and no topic is off limit. She gets it, not only as a functional medicine practitioner, but as a woman. One thing that she specializes in is aesthetic medicine, but her true specialty lies in treating the complexity of women's hormones because she has experienced it firsthand. She knows what it's like to be sleepless, tired, experiencing hot flashes while raising a family and running a household, as well as having a career. So she will personally attest that hormone therapy works wonders. And I'm a true believer that knowledge is power, and a woman understands and is well educated and intelligent on the subject and applies that knowledge. That is wisdom. So stick around. You're going to enjoy this episode. Please join me in welcoming Jennifer Gularson to the Menopause Disruptor podcast. Welcome, Jennifer. Do I call you doctor as a PA, or how do you like to go by?
Yeah, so I am going to probably anger a lot of my PA I just go by Jennifer. If you call me Dr. Jennifer, I have to tell you that I'm not a doctor. I'm a physician assistant, but a lot of people go like PA Gularson.
Okay.
That to me seems like it's more in the military, but I'm happy with anything.
Wonderful.
How about menopause helper?
And that's exactly why you're on the show. You're going to help us unpack it all. You come from a rich background in primary care. We were just talking about that functional medicine, Dr. Mark Hyman, kind of functional medicine, aesthetics, oncology, hormones, peptides. What initially drew you toward integrative approaches, especially addressing this in hormonal health?
Yeah, so sometimes you don't get to pick your path picks you, and that's sort of my case. I was very blessed to, after working in family practice and then some in oncology where I did treat a lot of breast cancer patients. Was pregnant with my third child and I was looking for something that was a little less stressful. So I joined a med spa and I was lucky enough to witness the doctor that I worked with go through menopause. And she was a trailblazer and a disruptor herself and continues to be. And we turned our practice from doing like the aesthetics, skincare, Botox fillers, and lasers. They had a very thriving practice. So there were a lot of women there. And we always found one or two a day that were like, yeah, I have these dark circles because I'm not sleeping. Well, why are you not sleeping? Because I have hot flashes. And like, oh, maybe that's something we should look at. I was, like I said, my supervising physician got into hormones and was trained, and then therefore it trickled down to me, and we started taking care of women. And we got them probably, I would say, like 75, 85% better. And then we launched into, well, let's look at their gut, let's look at their thyroid, let's look at their adrenals. And that went down the path of becoming certified in functional medicine, which looks at that whole person, those fundamental things that we can't ignore. And so that's why I'm here now. And I changed practices about 6 years ago. I'm now in the Rockville, Maryland area. I treat people from all over. And they, like I said, it kind of found me. There was a niche in this area, and I got a name for being compassionate, listening, validating, and helping them turn their lives around. And now I have a really bustling practice and looking to help people outside of the DMV virtually.
That's amazing. And thank goodness that we have that at our disposal to be able to operate in the virtual space now and to
Yes.
broaden our reach far and wide. So it's interesting when you say you found your niche. The niche has changed. There's been a real call for that. We are seeing that in the media. We're seeing that from celebrity figureheads that are really changing the narrative around how we address menopause. But it has only been in recent years, probably less than a couple of decades, even less than that, that we've seen these pivotal moments that have profoundly redirected science to look at women and women's health, women-centric, female-focused hormone health. What shifts have you seen just in the 6 years that you have moved into this, well, into your new practice, but probably throughout the duration of your career as a physician's assistant?
Right. So I would say that when I started at the med spa, so that was in 2007, I really aggressively started treating hormones, say 2009, 2010. So it's been about 15, 16 years. And back then it was like, very under the radar. People would come in and not say why they were coming. And we were disruptors back then. My colleagues thought I was going to lose my license and, this is dangerous, all the studies, even though we knew when we were learning about hormones in that functional space, we all knew that we just didn't see all these women on hormones. They weren't getting breast cancer. They weren't dying. They weren't getting heart disease. So we knew the studies were there, but they just weren't shared amongst the traditional, just let's say traditional medicine. So we were really under the radar for a while. And then I really attribute, there were really good things that came out of COVID and really bad things. But one of the things was there was a study that the Women's Health Initiative, most of your listeners probably know about the Women's Health Initiative that set us back 25 years. But there was a look back study that came out around 2019. So right on the cusp of COVID. And I feel like it got buried. But then after the smoldering, the ashes were falling and people really got into, and podcasts came about a little bit more.
Yes.
So we really started saying, wait a second, this study came out. We really need to look at this. It's not as bad as we thought. So during COVID I think women had time to relax. We slowed down a little bit. We took inventory. And then I think people got ticked that they were being neglected. We were no longer saying, well, we should just push through. We're busy, but we're not pushing through anymore. We're going to sit in our feelings, sit in our symptoms, and really ask and demand better. And I think this ball has just been, it's like a snowball effect that, oh, yeah, and here's this study, and here's this study, and here's this expert talking about it, and this women's group, and this celebrity. And it's just getting bigger and bigger because women have stopped saying, I just need to suck it up. And they're like, I just want better. And they're demanding better. And I think we're even seeing this in the millennials and the younger generation about perimenopause because
Yes.
because we're giving them permission to talk about this. And I'm a Gen X. I'm 53. So I'm giving my younger generation permission to talk about all the things that we just had to suck it up because you just had to do everything and just keep going.
Yes. Well, we thank you and your team for being those trailblazers that are really shaking up the arena on how we treat women's health, how we address hormone health. And not only that, how we look at the whole system, the whole body. So when it comes to root causes and the functional medicine, it's stopping, slowing down, and starting to ask those questions. And as you alluded to, asking why they're not sleeping, why their gut health has shifted, or why the hot flashes. So how do you explain that in the context? Because it's still kind of brand new. We are seeing a lot more of the influencers, and I'll say like Dr. Mark Hyman, who's very forthright in sharing what root cause medicine is all about. But how do you explain the philosophy to a patient, to a client who has only ever experienced traditional symptom focused care, and that might also include the pharmaceutical solution to their symptoms?
Right. I think that a lot of them come in as a last resort. I can't tell you how many of my
Oh,
new patients have seen 4, 5, 6, 10 different specialists. And our American system is really good if you're acutely ill. We are
mm,
hands down the best. This is where you want to be. We're just really not great with chronic care. And we're just not set up for that. So my initial consultations are 90 minutes. So I'm sitting down, I'm starting from the very beginning. Tell me where this started, and then we go throughout their entire life. And then we figure out how you got here. And sometimes them just talking about their journey, they put the things together themselves. So we talk about sleep, of course. We talk about what you're putting in your body, and then exercise, movement, their relationships, and their stress. A lot of times they're unaware of how stress, especially in the area that where we are, we're really close to our central government. So there's a lot of high stress and
yes.
anxiety in this area, and they wear it as a badge sometimes. And we help them say, that's not a thing. We need to relax, do things for yourself. So those are the 5 pillars, those, diet, what you put in your mouth, sleep, stress, relationships, and exercise. All of those are talked about in that initial consultation. And then modalities, some lifestyle modifications are usually suggested in each of those areas, in addition to some lab testing. And then once we have like a story, I tell their
Mm,
story back to them, they feel very heard. And then we come up with solutions. And sometimes at the beginning, it's a couple things. It's easy as, you're using blue blocking glasses or blue light blocking
yes.
glasses. Yeah, it can be as easy as that. I just recommended that today with a patient because she says she scrolls before she goes to bed. I'm like, oh, okay. Can you at least wear these glasses? Can you just block that blue light? Um, so it's implementing these little modalities, doing the testing. A lot of times we do, I call them a little bit funky testing. We go really in depth and then explaining what those results mean. If they can see on paper something that I'm suggesting or prescribing and how this can help and get to the underlying cause of why. Let's say why they're depressed, why they have a little depression. Well, it could be vitamin D. It could be your thyroid. It could be your hormones. It could be your partner. It could be your boss at work. It could be the gluten that you're eating. So that you could have a multitude of different things causing one symptom. And it's not that, and Mark Hyman's famous for saying you don't have a Prozac deficiency. We are changing a whole bunch of different things to
Yeah.
help get an outcome. And looking at people is as a whole person is very different than what they're used to. And sometimes they're uncomfortable and don't understand all the questions and why I'm asking them. But at the end, I think they walk away. They have been able to tell their whole story, and they've been heard, and they've been acknowledged and not told that they're crazy.
90 minutes. That is absolutely unheard of in our healthcare system. This is
It
one of the
takes
why.
that long.
Yeah,
It takes that long to get their story. I mean,
exactly.
some of these people have lived 55, 60, 70 years. How do you do that in 8 minutes? You can't.
That's right. And never have had the platform, the opportunity just to let it off their
Yes.
chest. And
Yes.
then in the moment that you recap their story back to them, you give logical explanation that suddenly it just builds a bigger picture. Stories are compelling, but when we get the real information, that data, that links, I mean, we are wise women. Stop treating us like we are not. Give us the information, and then we feel empowered to make radical
Good
change.
decisions. Yes.
Yes. Yes. I would be really curious if you wouldn't mind sharing, Jennifer, some of the outcomes or testimonies that you've had from some success stories with your clients. And then we'll get into the nitty gritty of what you're treating.
Sure. So some of the comments I hear, life changing, saved my life. Okay. So last night I was at dinner with a business colleague, and we were talking, and she says, "You don't understand. I tell everyone that you saved my life." And I said, "Anne, I didn't save your life. You just had hot flashes." But she said, "You don't, I was Googling, can you die from hot flashes?" and you
My
saved
goodness.
my life in my eyes. Another good stories, and I'm sort of putting a couple of patients together, is wanting to be intimate with their spouse, but they have pain or anxiety, or their body image isn't there, or their desire is low, or they just don't feel like it. And giving them back that has been that's a huge reward, reclaiming that intimacy with a partner. um, Helping people lose weight. I have as part of hormones, all those things need to kind of go together, but just changing a little bit of their habits on what they're choosing to put in their bodies can make a big difference in how they feel, how they sleep, and the weight loss. I also do aesthetics. So they're having their skin look glowing because of the diet that we've fixed, and their food allergies have been fixed. And then their skin looks a little bit more glowy. And then we do some microneedling, and they're happy about that. Hair regrowth, that's always a really good thing. And I think, and I hear this all the time, "You made me feel like myself again." Yeah, that makes my day.
So beautiful. You mentioned so many things that are tied together, but libido, for example, one of the leading symptoms that are reported, that loss of desire, intimacy, and sometimes the root cause is linked back to self-image and
Yes.
self-worth. And when they feel and see that weight gain and feel lethargic, or that loss of confidence that also is related to some hormone loss, and we'll get into that, then of course libido is going to fall off the radar. And it's the last thing we want to think about, is because we're still in that doing, caretaking mode. And oftentimes menopause lines so unperfectly with the
Yes.
sandwich generation, where
It's
we're,
really not fair.
yeah, caregivers of our own children and taking care of ailing parents too. And then we're right stuck in the middle. So there's no time to take care of ourselves. And so when you work with women with their libido, for example, and I wanted to jump on this one first, then maybe weight loss second, what is some of the first common causes, apart from what we mentioned, image, in terms of their hormone deficiency or fluctuating hormones? And what are some of the approaches that you in the clinic will take to address loss of libido?
I would say this is a perfect time to break for a word from our sponsors. Guess what? You, my listeners, are my sponsors. That's right. I would love it if you could support the show. Helping me will help bring these amazing episodes to you each and every week, just packed full of information to help you on your menopause journey. And to support the show, all you have to do is go into the show notes and click just above where you read Meet Your Host. In green is Support the Show. You click on the button and it'll bring you to a page where you have the option to donate monthly, 3, 5, 8, 10. You can be a loyal supporter for as long as you want with recurring fee as little as $3 a month and opt out at any time. Each investment goes directly back into producing episodes with even better content, improved audio quality, and will go a long way in bringing great guests onto the show.
This is great because I just had a patient today and this is her story. She's already on hormones. She's being treated. She went into menopause early. She is being treated adequately on hormones, but she's tired. She has no desire and a ton of vaginal dryness, which inhibits her from having sex. And she says, I've gone to my GYN, my family practice, and they don't really have much in the way of helping. So we talk about desire as a whole, whether do you have, and did you ever have it? Because I don't think I can make it magically appear if you never did. But if we do delineate spontaneous desire, meaning, and traditionally men have more spontaneous desire, or there is one person in the couple that's a little bit more spontaneous. And then there's responsive. So making them understand those two things. Did you used to have spontaneous and you want to get that back? Or are you just saying like, I would love to be more receptive to receiving and being intimate with my partner? So that's a clear delineation. Many things, physical and psychosocial, affect what happens with our libido and our passion. And there are many different modalities, and sometimes they're overwhelmed because I was like, we can do this, we can do this, we can do this. And when you come from a place like, yeah, there's nothing, to me coming and saying there's 5 or 6 different things I'd like to try, that can be a little bit overwhelming, but I think it also is reassuring. So we talk about communication with our partner, like where's your partner on? Are they on board? Are they aware? Do they understand what's going on? And why is it painful? So for this particular patient, she had multiple things. She was fatigued because she still wasn't sleeping well. She has a younger child, but then she also had a lot of pain. And some of the creams were messy and she didn't like doing that. So I'm like, well, we can modify that. There's lots of different things we can try. So we're gonna try those things. And then there's also some of the pills now that are Addyi is one of them, one of the medications for sexual dysfunction that now was just in America. We got FDA approval for postmenopausal women. That was a problem before. But we've been using it off label for both peri and postmenopausal women. So that's a modality to help her. There are peptides that increase spontaneous desire and libido.
Okay.
And then also hormone replacement, adequate. And then there's testosterone. So this particular patient, she is being monitored. And in my opinion, she's very well taken care of, except that she did specifically ask about testosterone. And a lot of traditional medicine doctors, physician assistants, PAs, NPs, they are not familiar with how to prescribe it. Plus they won't test for it. That was her particular thing that happened to her, is that they wouldn't test her and she was a little frustrated. So testosterone is a great help. There's just recently I've been prescribing vibration. So using vibrators externally, not so much internally, but externally. There's a great study out there that shows that increased blood flow, which if you think about some of the modalities, the Emcella out there and some of the Mona Lisa, they're bringing blood flow to that pelvic floor and to that vaginal tissue. So blood flow to the area equals like more moisture, elasticity, and it just augments everything. So a lot of times there's not one magic bullet. It's a lot of different things, but that also takes communication with your partner to say, hey, we're trying this. Not to mention there needs to be a safe space for that to happen. So finding time, scheduling time, blocking time, and whether it's you need a nice bath, some non-sexual massage, have a babysitter, send the kids away, send the dog away. I have one patient like, oh, we can't be intimate because we have a dog and it's in the room all the time. Okay, the dog needs to leave. And just shut down. The women's brains are going a mile a minute. We are silently doing the laundry, the cooking dinner. The lists are long and extensive, and we just need to shut down that brain and step into our femininity, relax, find the time, and then a lot of times the rest will come as it may, especially if physically you're well taken care of.
That's incredible. I really gravitated to what you said, the biopsychosocial aspect of
Yes.
our health. I like to throw in a fourth one, biopsychosocial and even spiritual. And you even said it, you tapped in it to reclaim our feminine divinity, like our feminism, that part of us that needs the self-care and nurturing. Do you work in that aspect? Maybe not name it spiritual, but encapsulate some modalities and practice that help the woman say, you know what, you are a feminine being. And as such, you need that nurturing, which is very much a feminine quality as well.
I think by virtue of where I'm practicing, I am surrounded by very strong women, pioneers in their industry. They're CEOs, they're leaders, even you can be the CEO of your family. So in this area, I feel like there is a very elevated woman, sort of boss babe, if you will. That's a little term, but they are commanders most of the day, making decisions all the way from what's the kids going to wear? What am I going to wear? That you're making hundreds and thousands of decisions a day. I really do speak to stepping out of that role and with your partner. So talking about letting your male partner be the male and let you be the feminine so that you can finally relax. And a lot of them like that permission to not be in charge, to relax, to let someone else take over for a second, to relinquish all of those responsibility and all those balls that they're juggling. And I would say that I had to do that for myself. I had, you make a lot of decisions. I run my own business. So giving permission to step into that, I think we've lost a little bit of that. And then as soon as you're done, you can go right back to bossing everybody around. But you do need to take care. If that is what will make you relax, then that is what needs to happen. So yeah, I address that. And some people look and realize, oh, I guess I don't allow myself to step back and let someone else take over for a second because I've been so in charge all day. So it's something that we do discuss. Yes.
Yes. So we've addressed libido, and you addressed testosterone as one of those modalities to address the problem. But I do like the way you say it's a multi-pronged approach and that you need to almost be experimental. Try one, and is it getting results? Maybe it needs to be layered with another modality or another therapy. But talking about testosterone specifically, and here in Canada, Health Canada doesn't prescribe unless you have hyposexual drive disorder, HSDD. And I think that is the truth as well in the United States, is that it's just not recognized as like estrogen therapy and progesterone therapy and the whole hormone or menopause hormone therapy, MHT, I like to say. But testosterone is earning its place in terms of getting real results. Do you see that there will be a shift in due time that prescribing a low dose testosterone for women will finally come online slowly as we start to see that the evidence is moving the yardstick forward? We're getting more research, empirical data to state that this is actually something that the woman's body needs just as much as estrogen and progesterone.
I think that we're demanding it, which is nice. So the way I explain it to patients is that if I show them that the lady today, she had no testosterone available, like it was low, could not find any, less than 3. So that there was no testosterone found in her body. I tell them there is no FDA approved testosterone. I cannot write a prescription and you go to your CVS or whatever and pick up a prescription. You can get a mail dosed and you're going to pay for it because your insurance won't pay for it because there's no FDA approved form for women. But that doesn't mean that we don't have a ton of data that it helps us. And in fact, we have a lot of safety data on trans men, born female, transitioning to men at 10 times the dose that we would give you, my patient, and they don't get breast cancer. They don't have heart attacks and have heart disease. They are fine. And we have a tremendous amount of data with those higher doses. So then, therefore, why would a 5 milligram dose of testosterone cream for women be dangerous? I know that it did help that the black box warning on testosterone for men came off a little bit before we got our estrogen black box taken off.
Yeah.
But I think it sort of opens the conversation. There's controversy over whether we will ever have a dose that's FDA approved, but more and more people are educating themselves. There's a ton of data out there. I particularly like to use compounding pharmacies because they can give me the right dose rather than someone breaking open a packet, splitting it into 10 different pieces and trying to figure out dosing from that. There's good and bad with changes of administration and stuff. Everybody has their own platform. I don't know. I would love to have them also. I know that during the Biden administration, they were trying to declassify it into something that's not a controlled substance because it creates a barrier to entry for some people. And then also that's why some of the healthcare providers in my area just choose not to prescribe it. But I think it's a tremendous help for many, many women. I'd say about 75% of them feel something better. And then the rest of the 25% are like, I don't know, but I know that it's good for my bones. I know that it's good for my brain. I know that it's good for my motivation. I know it's great for my libido. It has that oomph, that get up and go, make decisions, that kind of stuff. And they were missing it. Also, aches and pains. A lot of my patients find that the joint stiffness, in addition to the estrogen, because that helps with joint stiffness too, the testosterone helps also. And it just strengthens the muscles and the ligaments. It helps with bone density. We all had estrogen, progesterone, and testosterone. We were in our 20s and 30s and 40s. We should be replacing it for most people.
The Menopause Society has a statement, came out with a statement in 2019, followed by the similar statement, I believe it's 2022, or statement on menopause hormone therapy, or HRT, just basically disputing all the findings, 2002 Women's Health Initiative, and debunking some of the misunderstandings. Although it's taking a long time, and the ghosts of those headlines that came out back in the early 2000s still linger in our healthcare. But testosterone is one that they have not come out and updated the statement. It's because almost like science marches on, but it takes some time for maybe the advisory board or the review boards to finally say, okay, this is officially the statement on it. But you said, and rightly so, the demand is there. Right now, we're still limited to compound pharmacy. But with testosterone, do you envision that once the Menopause Society finally makes the official statement on it, or brings it back more to what we're finding with the empirical data that's coming out now, that we might finally see prescription-based testosterone?
So here in the States, we have to have a company that's willing to go through the red tape of going through the FDA and for what formulation. But I think there's a precedence, and maybe it would be nice if the people who are making some of the formularies, they just decrease the dose a little bit because they're already at like 12.5 packets. Can't we go down to a 6 milligram or a 5 milligram packet? I don't think that's. And I think Australia does have that. It's a 5 milligram packet. And I believe there's someone in the UK. I'm not exactly sure. There's somebody in the UK that, and it might even be the Great Britain, they allowed the 5 milligram packets. Because I do sometimes have patients who travel outside of this country, come back with packets and show me and say, this is what I want you to prescribe. And I'm like, we don't have that here, but I can get it for you. And it's just in a different modality.
It just seems ludicrous that we can create artificial general intelligence that can do just about any task and job that a human could do. But we can't whittle down a prescription of testosterone into a smaller package. And again, you said exactly why. It's the red tape, the bureaucracy that we're up against. But we'll still keep advocating and working with, thank goodness, compound pharmacies and
I just would like
physicians.
manufacturers to make more patches because they're always out. So, and I look at it that as a good thing because maybe more women are on it. So the demand is higher, but now we need the manufacturers to get that because I don't want any delays in my patients' care.
Absolutely. That's a nice segue, Jennifer, into another area that you work with in your clinic and yourself, and that is weight loss. And that's another one of those leading symptoms on that scoreboard that tends to disrupt us in menopause and gets the most complaints. So let's address that. And in terms of peptides as well. I've done an episode, but there's still so much more to unpack. GLP-1 agonist is coming on board full stream. We need to really start breaking down the stigma attached to it and explaining exactly how it works, why it works, and the advantages and disadvantages. So I would like to address it just from a very broader perspective, weight gain and some of the root causes that we see happening in women's bodies as they go through menopause.
So when a woman has no more hormones, their ovaries stop working, they lose obviously estrogen, and estrogen is really a key to unlocking fat and and when you have low estrogen, you have dysfunctional fat. So you start gaining in different ways. You start having inflammation. You have that cellulite because you get the striations because of the inflammation that's around the fat. So you really do need estrogen in order to lose weight. So replacing that first is one of the things, or maybe optimizing is important. Testosterone also, I feel, helps women with the joint stiffness. So if they're not working out because they have joint stiffness, it's almost like what comes first, the chicken or the egg. But making sure that they can perform weightlifting and walking. So losing the hormones changes the way your body stores fat. And the other thing I think that happens is we are, especially in our 20s and 30s, told that we need to exercise, cardio, 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 cardio. And it's really great to see the younger women in the gym actually lifting heavy things, doing good technique, learning this because they are going to be so thankful in their 30s, 40s, and 50s, and even beyond that they're doing this. So I think getting off of the rat race and killing ourselves with a lot of cardio, which spikes your cortisol, which then makes it so that you become insulin resistant, you gain weight, and then you're fighting a whole nother battle. So adding stress, cortisol, an already stressful woman is just stress on stress. And then your cortisol increases, and then you're not sleeping, and then you're gaining weight. So making sure, again, starting at the beginning, looking at their gut, looking at all their habits, sleep, stress, what they're putting in their mouth, and then the movement is really, if they're not doing those things correctly, then I can't guarantee that what we do, even if we use a peptide or whatever, that's going to help. So starting with some interventions diet. I work with nutritionists. I work with dietitians. I give recommendations, but I am not the accountability person, but I give them recommendations and then have them work with people what is a plate with 20 to 35 grams of protein look like and 40 grams of fiber? Like, what does that look like? That's your job, is to figure that out. And then make sure that you're fueling. I think women often, because, well, at least my generation, we grew up with diet this, diet that, less calories, starving ourselves, yo-yo dieting and things like that. And then there's the whole pasta snack wells, high carb, low fat, all that. There's just a mess right now with what we're supposed to eat. But I think the message is pretty clear. Lots of protein, lots of fiber, lots of fruits and vegetables. And then all the carbs can be extra, and don't be afraid of fat. So doing all of what you're fueling your body is the first thing. Getting your exercise dialed in is the second thing. Getting your hormones, your thyroid, all your supplements, nutrition, your gut. Are you absorbing everything? All that's great. Okay. Now we can talk about peptides and whether it's, I start them out on some berberine, which is a nice blood glucose regulator, and they sort of get a little bit of benefit from that. And then then I can go into the peptides. I tend to enjoy going low dose first. I like to microdose. I think that a lot of the side effects and the scariness of some of the peptides or the reluctance is because of some of the side effects that people have seen: hair loss, diarrhea, constipation, nausea. Those things happen usually when you escalate too fast and you're not following the rules. You're just not doing what you're supposed to be doing. I often tell patients, if you're not eating, you're taking too much. So I think we went and took a medication that was aggressive in lowering hemoglobin A1C for diabetics. And we took that exact paradigm on how to treat weight loss. And I think it probably was too much. I just get a lot of success with patients who are doing everything right. I mean, no one's perfect, but doing as much as they can, starting at a low dose, maybe a quarter of a starting dose, and then escalating only if they're having trouble and they're not losing. If my patients are losing a pound a week, I am happy and okay. If it takes them 6 months to lose 15 pounds, 20 pounds, I think they're developing the skills to make a good plate, that they're lifting heavy weights, they're getting their hormones done, they're sleeping, they're doing all the other stuff. If it takes them that long, they are more apt to have lifestyle changes that are going to change their life long term so that they can keep that off. It's these, and their skin isn't saggy. So then they're not having to do interventions for that. That's my philosophy, is go slow, start with the basics and go slow and escalate up as needed, and then probably back off a little bit and maintain. I used to think that maybe we should stop them, but there are so many health benefits to remaining on these medications, probably at a much lower dose than what we got the patient to lose the weight at.
When I hear all of this, I think in terms of interventions, and women just don't want to do the lifestyle changes or even integrate behavioral changes when they're feeling low energy, not feeling themselves, feeling low libido, not intimate with their partner, which is an additional stress, workload, their careers, like all these things, like you said, these stresses add on. And so they're not remotely interested in investing in some of these interventions when they just don't have the intestinal fortitude to do it. And yet we are understanding now that interventions such as hormone therapy, I hate to say replace or replenishing, so MHT, including testosterone, is bringing back that sense of self, a little bit more vitality, also aiding in, like you said, the brain, the muscle. But yet it seems like our healthcare system is too readily available or willing to jump on the GLP-1's agonist prescription before we could push the yardstick and get testosterone. There's still so much more gray area and taboo around hormone therapy. It just seems like there's a real disconnect. What is happening in the healthcare system? Why are they so eager to prescribe for weight loss but not manage hormones for women?
They were never taught how to manage hormones because hormone replacement was bad. So there's no education, and that's not their fault. It just, that is. And I do some teaching in PA programs currently, and there still is no hormone replacement or therapy taught. Certainly not testosterone stuff. And then time. They don't have the time. So to sit and talk about why eating cues or what's driving, or do you have repetitive thoughts? Like there's just a lot of food noise, talking about food noise. Where does that come from? How are we going to stop that? What is your sleep hygiene? That none of that. I never learned any of that. I learned that all in the functional medicine course. And that's like a 2 or 3 year course where you are learning all the stuff that we should probably be learning as healthcare practitioners. But the thing is, you can partner with, you can have people in your office that do that stuff, or group visits where you learn all of that. But it's the education. We just don't know. And it's easy to write an FDA approved. If your insurance pays for it, okay, here you go. I inherit a lot of patients that just don't understand what it's supposed to be doing. I have one patient I inherited, and she's like, I'm on this medication and all I eat is 3 Skittles a day. I'm like, no wonder your hair is falling out. No wonder you're like, you don't have any energy. So I think it's the crutch is not a word. It is an augmentation. It is a helper, but you got to, yes, do all the other stuff. And I will start women on a really low dose to sort of give them a little bit of a nudge and a little bit of hope, because if they leave with nothing, they feel defeated. If they have a little bit of a tool, whether it's a prescription for testosterone or an estrogen patch or a lab slip that's going to see, or a low dose GLP-1, and a prescription to go see a nutritionist, it gives them the power back. At least they have something. I think that's giving them hope and listening and saying, I promise I'm here to help you. This is a relationship. We're going to get through this together. But listening, validating their feelings, and giving them a little bit of hope is really, really important. Traditional medicine doesn't have the time. I feel so bad for my colleagues who are seeing, if I see 12 patients a day, that's a lot for me, because it's either a half hour or 90 minutes. 12 patients is a lot, 12 to 15. My colleagues are seeing 30, 40, 50, and it's, in and out, in and out, in and out. If you are really sick in America, it's a great place to be. If you have a chronic disease, not so great. We're just not prepared. We just have to change the paradigm. And then we also have to reimburse for health. We reimburse for sickness.
You read my mind.
Sometimes I'm struggling, especially if I have a really dialed in patient and they're just looking for optimization. So I have a lot of patients that come in like, I want to optimize. I want to outsmart my genes. My mom has dementia. I don't want it. What do I do? And they are doing everything right. What do I put on there as a diagnosis? Like they have no complaints. They're optimized, but they're looking for a genetic test that looks at all her SNPs or his SNPs to say, oh, I should be taking this type of B12 so that I can outsmart things. How do you bill for that? It's hard.
And it just seems the first test it has to pass is the judgment. You have to be able to explain your positioning. I'm in great health, but I want to do better.
Yes.
And yet here are healthy patients still having to explain themselves away. Yeah, I was going to ask about that reimbursement. Here in Canada, of course, we have a healthcare plan, and a lot of our healing modalities, including going to see your doctor, telehealth, even nutritionist, naturopath, osteopath, all those modalities, by and large, insurance companies will cover to a significant point, not all of it. So that makes it more readily available.
Yes.
But then there's other avenues where if there's no reimbursement, there's no investment. And this is where the things that can really help them. And I'm speaking in terms of gym memberships, a personal trainer. Even working with someone like me as a doula helps unpack, like you do, getting to the root cause, building the story, and then farming out, making referrals to the specialists who can apply the therapies, if you will, of the prescriptions. But it just seems that if I'm not going to be reimbursed, what's the incentive? Like you said, unless you're very clear in your mind and you can connect the dots. If my gut microbiome doesn't have good diversity, I'm setting myself up, or if I have high insulin, I'm setting myself up for increasing my chance for dementia and Alzheimer's. But that language is not in our medical practice at the moment. We haven't connected those dots. And yet we're on the precipice of change. I see that, but it's unfortunately, and that's what my point was. It just seems here in Canada, we're at the mercy of what the insurance company decides. what will get reimbursed. And yet there's so many different other like somatic therapy and yoga. Like these are trauma-informed yoga. Like this is stuff that gets really to the root cause that trauma stored in the body. And Mark Hyman speaks about this too, that can be really aiding in someone's health journey, not sickness journey, but their health journey.
Yeah, they want to know what your diagnosis is and what's the prescription we're going to fill it with.
What else can we see happening maybe in the future where we're really starting to see more shifts in proper health care as opposed to sickness care?
One of the exciting things that I see are more peptides. Of course, there's
Okay.
going to be more and more and more, not just for weight loss, but also some of the ones for ligaments, for tissue recovery, for
Wow.
human growth hormone secretion, for decreasing inflammation, other places, mitochondrial health. So all of those things that all signal decreased inflammation, which equals longevity at the end.
Mm-hmm.
I also see more attention to the gut microbiome, which is, if you go way, way, way back, all disease starts in the gut. So that is exciting. And then also personalized medicine to the point where you're looking at your genetic makeup and some of the SNPs or the oopses that have happened in your particular genome, and then
Wow.
devising supplements, diets, lifestyle interventions that circumvent those genetic, I call them genetic oopses because not everybody knows what a SNP is, but those like genetic things that are creating long-term problems. But wouldn't it be nice if you had a 6 or 7 year old and you did a genetic test on them and it gave you all the answers that they're predisposed to ADHD. So then you start them on magnesium at a young age, or you start feeding them certain
Oh,
types of foods, or
so
you
good.
know that they have a gluten sensitivity. So you just stop that right at the beginning. Or that they have the MTHFR where they can't methylate as well. So then you're feeding them more cruciferous vegetables, or you're giving them a certain type of B vitamin and the magnesium. And that's where medicine is going to be at some point. And there are some practitioners that are there. And a small part of my practice is that. So I think that's really exciting. And that's when you're going to get the longevity. And you don't just want longevity, you want to be able to move around. You want your brain to work. You don't want to live
Of
to
course.
100 and not be able to use it. So that's
Yes.
where I see that happening. And with AI, you
I was
can
just about to ask.
put in that genome and it will say, these are the things. And research, research needs to catch up to the entire genome sequence, but putting it in AI and then saying, create a 2-week diet for me based on my genomic makeup and how I'm
Wow.
predisposed to gain weight in certain areas, or like I can't tolerate this amount of carbs. All the information is in there. It's just being willing to go from a diagnosis type of society, or we wait until there is a problem in order to address the problem.
Yes.
I think, in women's hormones, we are now looking at prevention versus misery. Before 3 or 5 years ago, the modality was, well, okay, now you're still having hot flashes. Okay, now you can qualify for some of these supports. You're really not that miserable. I'm not going to risk it. That's gone now. We're doing more preventive. We want to save your bones, your brain, your muscles, your everything. But we're not there yet with everybody else. So when we go to that prevention mindset, which is what we were back in the 50s, 60s, 70s, you had your primary care doctor and they knew everything about you. And now we just have so many specialties, which is great. But then the infrastructure is not there to take care of people as a whole. Yes, we need our
Mm-hmm.
specialists. We need a person that does very, very specific work, but we also need the people to cultivate at the root level of your health and keep you healthy that way. So prevention
Yeah.
versus like, the house is already on fire and we could have prevented it by putting the fire screen up.
That's right. Right now, things are still very siloed It's to treat what's
And no
happening
one
rather than
communicates with anybody. Your neurologist doesn't really send it to your lung doctor, to the cardiologist. They never talk. And then they are very, very siloed. And I don't know about hormones. I'm not going to say yes or, they put, this is where I am, and I don't have any opinions about anything else. Go ask
Yes.
that person, which I understand, but we have nobody to keep these people whole.
The AI arena. I mean,
Yeah.
I could talk at great length. I'm a science communicator at heart, and I could really geek out on the science. But I could see an AI information war evolving in terms of if we have this capability and it maps our genome and gives us the lifestyle choices to support so we can prevent or improve. That circumvents traditional medicine in terms of pharmaceuticals.
Oh,
I can really see a real war on this happening. AI could be used to our advantage in this case, to our advantage, but it would cut out a couple of things, maybe even pharmaceuticals, or significantly reduce. And it would certainly put a real wrench in manufacturers who are constantly producing sugar-laden foods and keeping the consumers buying because they're on this sugar rush and cravings.
oh
And that would
yeah.
be a real disruptor too. So we finally put a stop to that because we're now realizing. And so much faith is being put into the results that we get from our AI.
I have
Ever
patients
before.
now come in and we finish like we go over everything. I come up with my plan. We have our discussion and they're like, okay, cool. And they pull out their piece of paper. They're like, you said exactly the same thing as my AI. And I was like, I'm glad you didn't tell me you did this beforehand. You would have scared me. But yeah, they're like, oh yeah, we agreed on this and this. And my AI said this. And I'm like, okay, yes, no, I don't think that's a good option for you because of this. And so I may become obsolete. I'm sure a lot of my patients think that too.
I still think that accountability partner, that coach in the corner, the one
Yeah.
that's cheering you on, is still a human experience that I don't think
Oh,
any
yes.
AI
And
system
I don't
can.
know that AI can talk about the intimacy, the communication. Yeah. I think if AI takes over after I retire, that'll be fine.
I knew this conversation was going to be both interesting and disruptive. We've taken it
Yes.
from talking about our intimacy and libido right on to AI. And you know what? In this day and age, that's exactly what a lot of conversations are all about.
Absolutely.
Wow. You said something, this is my science brain geeking out now, MTHFR, when it comes to some of the diagnostic that we could read. And if we have that information, we can introduce those modalities. So just define that for the listeners.
There's a couple of things. So how you break things down, especially hormones, is really important. So we have things like the Dutch test that looks at your metabolites. But genetic wise, there are some people who can't methylate or can't detoxify our hormones in the proper way, or they do it very slowly. So there's things that help to speed up that process. And then there's other one like COMT, that's another one. If you have that is for estrogen metabolism and estrogen detoxification. So everything we put in our body, we need to break down, whether it's air, food, medications, and they're genes that turn things on and turn things off. So when we're specifically looking at hormones and creating hormone replacement and putting in sometimes synthetic, then there are going to be some repercussions, and your body's going to have to work hard to digest, if you will, or detoxify things. So knowing where your vulnerability is, whether you have a COMT SNP where you prefer a different pathway to detoxify your estrogen, and therefore you have to take some things like DIM or methylated B vitamins, methylation enhancers, or SAMe, that's another one that sort of gets things going through to help you detoxify things, or you may need less of something. You might not, and not everybody's the same. That's why some people at a low dose of estrogen can feel breast tenderness, and people that take 10 times as much, they don't feel any breast tenderness because of the way they break things down. So that's where it's a little bit more nuanced when you're looking at your specific genetic makeup. But it can give you some ideas on how to be safely on hormones and how to break them down and detoxify them, as well as other medications that you may take.
Very great explanation. Really, honestly, it's the first time I've really heard it explained in such simplistic, understandable detail. So right now, the tests that are available for us to know our ability to break it down, to be able to absorb the hormones or whatever we might be on, what tests are being used right now to be able to determine if we can do that effectively?
So there's two things. Number one is the genetic test. So you can get your genome mapped out and you can get some of this done. We work with a couple different genetic companies. And then you can also do different panels. There's a neuropsych panel, like if you're having trouble finding out which medications would work best for you. Then there's also detoxification panels. So there's different panels genetically. Then as far as hormone testing goes, the Dutch test is really great. I don't use it for dosing, but I usually have once a year or once in their lifetime, look at how do you process hormones and are you putting yourself at risk? So when they look at estrogen detoxification, if you choose one specific pathway, because that's the way your body is made up, there are some supplements that I can put you on to push you to a better pathway. So there's three different ways to detoxify estrogen. There's the good prep pathway, the bad pathway, and the it's okay pathway, but we don't love it. So we can take medications like DIM to push it down that good pathway. And then we also need to make sure once you have that first pass metabolism, those are all the free radicals that are out there. So we know what free radicals are. Then you have to take those free radicals and use things to get them out.
Flush
second pass metabolism. And we use oxidation, we use glutathione, we use our B vitamins. And so knowing how you do that, the Dutch test is really great for you specifically, how you process things. And if you're in danger, if everything looks great and you're on hormones and all your metabolites are within normal limits, that's great. If they're a little bit off kilter, then we can outsmart it and put things through to help you detoxify a little bit. The same thing goes with testosterone breakdown. We're always looking for DHT. So if you prefer to break down testosterone in an alpha pathway, we can give things like saw palmetto or finasteride, and those will inhibit the DHT and push it down the other pathway so that you don't get the acne, the hair growth, and then the hair loss.
Interesting.
It's pretty cool.
Absolutely. And I'm sure that there's some listeners right now thinking, wow, I want to be able to have somebody lead me down this pathway so that I can get the right tests and I can optimize my hormone therapy, optimize just my nutrients or my supplements. And this is wonderful. Again, like I said earlier, we live in a day and age now where we can work virtually. And that's exactly what your clinic can do.
Yes.
So Jennifer, please tell the listeners where they can find you so that if they're far away in the United States, of course, only, they can still take advantage of what you have to offer.
Sure. Yeah. So if you're in the DMV area, which is Maryland, DC, Virginia, that we see patients in person. And if you're outside of that area, my website is yourbestlifewithjennifer.com. And I probably would not be able to prescribe for you, but what I do offer patients is advocacy. I can go over all your labs. I can tell you what to order, and then I can work with you to find a practitioner in your area that would be able to prescribe what we come up with. So going through your labs, figuring all that stuff out is great, but then you need somebody to sort of take over your care and help. I'm always here as an advocate for people to find the right practitioner in their area. They're out there. We just need to find them, or we just work with them and we educate them as we go, which would be great.
Exactly. Perfect. And that is, of course, for the United States. You're not working abroad outside the United States at the moment. One day we'll come to a point where it'll be more universal care.
Yes, that would be so great.
Yes, there's some cutting edge medical care, if you will, or health care in places all over the world. You mentioned a few, Europe, Australia. It would be wonderful to have the same advantage. But until such time, this is for our United States listeners, but you still gave us a wealth of knowledge that is universal So I'm sure a lot of
Absolutely.
listeners will take away a lot. We will get all of those links in the episode description. Thank you so much, Jennifer, for joining me, sharing your expertise, unpacking a lot of the confusion in our midlife journey, and really empowering women with the knowledge so that they can make wise choices.
Thank you so much for all you do, Mary. You're a blessing.
Lots of aha moments in this conversation. As always, that's why I bring the guest experts onto my show. From this conversation with Jennifer Gularson, these are my key takeaways. The importance of holistic root cause approach to menopause and women's health. Integrating functional medicine in today's medical system. So important because it gets right to the heart of the matter. Asking curious questions, building a story, and looking at what might be causing some of the symptoms as opposed to just masking them. Deal with it. And this also involves a practical approach to lifestyle changes and hormone optimization. Again, it's just not about symptom management, it's about optimizing our health. Jennifer also highlighted the cultural shift that's underway because women are demanding better care and more information, which is driving advances in research and care options. Jennifer also outlined her 5 pillars for health. They mirror a lot of the work I do as a menopause coach. What you put in your body, how you rest your body, sleep, stress management, relationships, and of course, how we move the body. And Jennifer also stressed the importance of understanding each woman's backstory so you can tailor her menopause journey for success. Hormone therapy. Yes, the traditional estrogen, progesterone, but understanding the role that testosterone plays in a woman's body and how we can advocate for testosterone replenishment, very important. But right now, in Canada and the United States, not all places worldwide, but certainly here in North America, we are limited. Unless you have hyposexual drive disorder, HSDD, then it's very hard to get a prescription-based medication for testosterone. But very important that you do your homework, you do your research, present your case to your doctor, and advocate. Testosterone just might be one of the 6 hormones your body is lacking for brain health, recovery from exercise, sexual desire, and just that feeling of being yourself again, being whole. We deserve this. But there is still slow progress in mainstream acceptance of therapies like testosterone for women, and so more advocacy and demand are driving the change at the regulatory and educational level as well, where we continue to see some of the barriers. The role of peptides and GLP-1 agonists featured recently with my conversation with Dr. Sarah Tarek. It's a conversation worth having again and again because weight management and weight gain are 2 areas of prominent concern in the menopause journey. And there's many reasons for that. If you're considering going on GLP-1s or you're already on GLP-1s, understand that they are there to complement, not replace, core lifestyle changes. Working with a team such as nutritionist and incorporating other lifestyle changes, including my favorite, exercise, strength training, resistance training, so vital. Whether you're on GLP-1s or not, your body has the ability to improve health markers if you just move it and fuel it effectively. And that's why working with the right people in your care team can help you with that slow, steady, sustainable progress. What I found a really crucial point in this conversation was the importance of understanding how women detoxify and metabolize medications and hormones differently. And some genetic differences can influence how hormones are processed, affecting both safety and efficacy of these therapies. And then we looked at the big paradigm shift, shifting the mindset from sickness care to health care, with the main focus on prevention and personalized medical treatments and holistic modalities that are unique and individualized for each person. And that's when we had that little discussion about the future, where genome mapping and AI will enable even more personalized and precise healthcare, helping practitioners tailor diets, supplements, and interventions to each person's unique genetic makeup, and more so, empowering women with information and support that they deserve. Being the true disruptor that Jennifer is, she discussed how advocating for women to reclaim their health and embrace their femininity is vital, as well as seeking practitioners who will listen, validate, and partner with them on their journey to optimal health care. You can find Jennifer on her clinic's website, Osteopathic Center for Healing, ofchealing.com. And you can also find her on yourbestlifewithjennifer.com. She's also on Instagram at Jennifer Gularson. All those links will be in the episode description below.
If today's insights resonated with you, I'd love for you to be a part of our growing community of menopause disruptors. Hit that subscribe button wherever you're listening right now. And if you know someone who can benefit from these conversations, please share this episode. Sometimes a simple act of sharing can be the first step in someone's healing journey. And hey, if you're ready to take the next step in your menopause journey, I'm here to support you. You can find all my services, including my comprehensive menopause intelligence digital course, one-on-one coaching programs, and workplace education services at mlcoaching.com. It's in the show notes. Want to stay connected and get regular doses of menopause wisdom? Follow me on Instagram at Menopause Disruptor Podcast, where I share tips, insights, and real conversations about navigating this transformative phase of life. Let's continue to disrupt this menopause conversation together. Remember, midlife should be the best life, and it will be. Namaste.